بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سعادة الدكتورة حنان محمد الكواري وزيرة الصحة العامة، سعادة الدكتور حجر أحمد البن علي رئيس المؤتمر، أصحاب السعادة، ضيوفنا الكرام، أيها الأخوة الحضور، الأطباء الأفاضل، السلام عليكم ورحمة الله وبركاته. نرحب بكم في هذه الأمسية الجميلة، ونحن نعقد هذا المؤتمر 14 لجمعية القلب الخليجية، والمؤتمر 11 لجمعية الأوعية الدموية، هنا في دوحة الخير، في دوحة المحبة والسلام. خير ما نبدأ به مؤتمرنا آيات مباركة من كتاب الله الكريم للقارئ عبد الله المهدي.
أعوذ بالله من الشيطان الرجيم. ولقد خلقنا الإنسان من سلالة من طين ثم جعلناه نطفة في قرار مكين ثم خلقنا النطفة علقة فخلقنا العلقة مضغة فخلقنا المضغة عظاما فكسونا العظام لحما ثم أنشأناه خلقا آخر فتبارك الله أحسن الخالقين. صدق الله العظيم.
Our guests from everywhere, welcome to Doha. Doha is the capital of Qatar. Doha is the city of the peace and city of the love. Welcome all of you for the 14, the Gulf Heart Association, and the 11 for the Vascular Conference. We're going to start our speakers today with Dr. Hajar Al-Bin Ali. I'll give you just a brief case about Dr. Hajar Al-Bin Ali for everybody. Dr. Hajar Al-Bin Ali, he served as the Minister of Public Health from 1999 to 2005. Prior to being appointed as a minister, he was Under Secretary of the Minister from 1981 to 1993. He was appointed as a Public Health Advisor to the Emir of Qatar in 2005. Dr. Hajar held a chairman position in several organizations, including Hamad Medical Corporation and the Gulf Heart Association, an organization which he founded in 2002. Welcome, Dr. Hajar.
Thank you, Mohammed. Her Excellency, Dr. Hanan Al-Kawari, our Minister of Health, Professor Mohammed Zubaid, President of GHA, Dr. Kadhim Suleiman, our GHA President-elect, our distinguished guests and colleagues, ladies and gentlemen, Assalamu alaikum, good evening. On behalf of GHA branch in Qatar, it gives me great pleasure to welcome you and thank you for attending and participating in our conference. I take this opportunity to thank also our Minister of Health for her support to our organization. My sincere thanks to our scientific committee, especially its co-chairman, Dr. Awad Al-Qahtani and Dr. Jassim Suwaidi. Dr. Awad Al-Qahtani always trying to hide in the dark and does not want to show himself. Where is Awad? Awad, stand up, please. Let us see you. Awad is the dynamo behind the activity of this conference. Many of HMC staff deserve our thanks and appreciation for their help with this conference, and also I would thank the sponsoring company for their contribution and help. Our GHA President, Dr. Zubaid, was very active during this term, and he gave us, for this conference, a lot of support from the beginning, and he deserved and thank. I'm sure that the new president will follow the very active role of Dr. Zubaid, and we in the Gulf, we grew up hearing that the Omani have a lot of magic to do miracles. We don't mind if you use magic to push our organization further. 16 years ago, in this country, Qatar, in this city, Doha, in this hotel, Sheraton, in this hall, the Majlis, and it was January of the year, also the same month, I stood here and announced the formation of Cardiac Society for the GC countries, after reaching unanimous agreement between us, cardiologists of the Gulf, meeting here. They elected me at that time as a president, and they re-elected me for 12 years, which is unusual for you, but it's not unusual for the Middle East. Usually our political president are a president on that chair until they bury them. That's no exception. During this 16 years, between that conference and this, great progress was achieved in the therapy of cardiovascular disease. Our distinguished guest tonight and during the conference will update us on the development and progress. But my task today is not updating you on anything except entertaining you. Dr. Zubaid contributed 10 minutes of his talk and gave it to me, so I could relax and take more time. Now, before we go into the history, I will add one more thing. My co-founder of the organization, that they are with us in the hall, probably forget that we didn't call it that day Gulf Heart Association. I will be glad to show you how we came to that name. I sent a letter with 5 choices to choose the names, and one of them was Gulf Heart. The majority voted for Gulf Heart. Dr. Kadhim, you deviated from us and your vote was different, but still we'll forgive you. So that was the historical vote. Now, I had a dream during fellowship and residency to establish cardiovascular care in Qatar, creating Gulf Cardiac Society with my colleagues. Later, the dream during work is to have a heart hospital in Qatar, have a heart house in Qatar, and Pan-Arab Cardiology Society for all Arab countries. Unfortunately, I did not achieve what I want, but some are achieved. Now, as far as advanced cardiac care, I will discuss it. I will not say we achieved, but I will discuss to you how we progressed. Cardiology now is 40 years old. We started in 78 until now. But landmark in the history of healthcare in Qatar, the first hospital was built in 1945, Doha Hospital with 10 beds, and one doctor and his wife. That is before that, the healthcare in Qatar was going with the old traditional medicine, herbal and cautery, bloodletting. That was what was used. But that was the first westernized medicine start in 1945. And in 1957, Rumaila Hospital was opened, and that was a show. People from the Gulf come to see this miracle hospital because it's very advanced for those days. And then the Ministry of Health, like other ministry, created in 1970. Before that period of time, the British were in control, but they announced they want to withdraw from the Gulf and leave us alone. And Qatar was independent in 1971. But before that, the formation of Ministry of Public Health. Incidentally, during this time, I was absent. I was not in Qatar. I was in US for pre-medical college, medical school, internship, residency, and fellowship. 14 years absent. I came back in 78, almost a stranger to the healthcare. And so that's when we started cardiology. And in 79, we opened our first modern CCU in Rumaila. The concept of CCU was not really available at that time in the area. And then we opened Hamad Hospital, and I was in charge of the commissioning of the hospital 2 years later, and we adapted things for the cardiology and also for the rest of the hospital. And then the last is our heart hospital. And so cardiology stayed 4 years in Rumaila before we moved, and Rumaila converted to rehabilitation. And then 29 years in Hamad, and now last 7 years in the heart hospital. Just to give you a briefing of the healthcare in Qatar, at the time I came, the population of Qatar about 200. And we have 2 hospitals. Women for only obstetric and gynecology, and Rumaila is the only general hospital in Qatar for all the country. And the Rumaila was divided in 2 divisions, surgical department and medical department. And in medicine, there is internal medicine. At that time, there are only 3 consultants and some junior doctors. Pediatric was part of medicine officially. And the only intensive care in Rumaila was in the surgical department. So when very sick patient in medicine will be transferred to surgical side to have better care. I came and they were very generous. There was CCU room were allocated for me. It's coronary care unit. It was not coronary, it was not care, but it was a unit. This is the bed. This is actually from the CCU bed. It's an ordinary bed, no monitor, nothing. And we found in the store some old monitor Siemens that being dusted. The engineer were able to fix it. I put it for a patient if they have atrial fibrillation during the time I talk to them. At least I feel good to see some monitoring system. But we remove it afterward. And the nurses were nice, not me. They are the one who did the logbook for us. I still have it. This is the logbook. We converted later on to a real database, but you see that at least in this one, too many patients expired. After 2 months of major deficiencies in the department, we had no devoted nurses for cardiology. We had no resident, no echocardiography, no cardiac clinic, and not even an office for me. And I was on call 24-hour, 7 days a week, all the time, until a few months later we started getting staff, and a year later we have a consultant to help. But our mother department is not better off. They do not have subspecialty, all general. They have no ICU. There is no medical equipment. There is no CPR known in the country. Nobody does CPR and nobody hears about CPR. No medical record. The patient, when discharged from the hospital, they take the paper and give him the patient to take home. Sometimes the goats eat it and nobody see it again. And no doctor on call at night. The whole hospital, both surgical and medical. The doctor goes home and sleep, and they call them if they need them. No appointed system for outpatient. There is no ECG service. But this is not the fault of the internist. And so what was the hope that we could progress? How? The idea, if we could create a small department, not big, then we could manage it and improve it. And that was the hope I had, to make cardiology in a small independent department so we could proceed. So the plan is to be patient, be honest, work hard, and push for progress and pray. In that order. It so happened that on Friday, the 24th of November, 1978, an old man came to us with syncope. He's 80 plus years old. Abdullah al-Mishhadi is his name. With syncope. It's clear he had complete heart block. Of course, we have no pacemaker in Qatar, and actually not probably in the whole Gulf. So I called the embassy in London and asked him urgently to send me. I sent telex what I need. And they were, within 24 hours, I have pacemaker. I put the pacemaker on this man, and it hit the news all over the Middle East, newspaper, talking about this miracle advances in Qatar. What we benefited from is a broad government support, public support, and pressure for cardiology to be built up. So we felt stronger. And so I put a demand to the hospital administrator that we need larger room for CCU, we need more nurses, only cardiology, and ECG technician and office in the clinics. All of these granted to us immediately, and we proceeded. And so in the first 4 months of our work, we have some more manpower. My wife was a resident that I met her in US. I took her as one of the house officers, and 2 doctors from internal medicine. One of them is still in Doha working. A Somali nurse, we convert him to learn ECG, and we start doing ECG in the hospital. They gave me 6 nurses to train for cardiology, but they belong to the nursing department of internal medicine, not completely our. I started arrhythmia and CPR training, and we now could afford putting a 24-hour monitor. The second step came. All those nurses learn how to do CPR, and I wrote down that in case of cardiac arrest, a nurse could start CPR until a doctor comes. They are all experienced now. It happened when past midnight, one patient had ventricular fibrillation, one of them my patient. And so they ran for resuscitation, and our nurse took the paddle, went to defibrillate the patient. When the head nurse of the Department of Medicine was there, she held her hand and said, "This is not for nurses to do. Call the doctor." She tried to explain to him that she is capable, but she didn't allow her. So she had to call the doctor at home, wake him up. He came 25 minutes later to write the death certificate. Now, the following day, I called the chief of internal medicine, the administrator, the head of nursing to the CCU, and told him that this is considered crime. The interference in the Department of Cardiology is not acceptable because we are losing patients because of your interference. And this, if it goes to court, you will be all going to jail. By the way, my father was the chief judge at that time also, and they know that. The chief of medicine announced that cardiology is independent as far as he's concerned. The administration agreed. And so that's the day when our department became independent department, and we get bigger space, and now we have 6 monitor beds. Equipment came to Hamad Hospital, we borrowed it and made the CCU. You see now, the patient each patient have defibrillator and monitor, and the nurses and this is something you don't have in most hospitals. And I didn't have a clinic, but I was doing record first using this 6x6 card. I saw the pediatric department doing it, so I follow them to keep record of my patient. But later on, I asked for a porta cabin. Nobody is using it. They gave it to me. We converted it to a clinic, ECG lab, stress test, and medical record section where we keep. And this is the first medical record in Qatar formally was made. And then we get the echo machine in development, and the nurses were keeping the log of the cardiac arrest. Look our survival in the first 2 years. Comparingly, it's not very bad. The survival in hospital cardiac arrest, not outside, 36 and 43. And our next jump was in the September 79, when cardiology have a ward of its own, modern CCU, and that was good news for us. In fact, I did a cath lab unannounced just in the one room of the CCU. I converted to the cath lab, a fluoroscopy machine, and the company put for us a recorder of this tape, the old fashion, and monitor. And the hospital carpenter made a wooden table. It was functioning very well. That's our cath lab, and we were in option. One interesting story that Dr. Hanan has to know, in 1979, there was, I will not mention the name of the neighboring country, they brought a cardiologist from Texas to see an aunt of the head of the state. She has heart failure, an old lady. He wanted Swan gangs. Nobody heard what Swan gang. They told him that, they called me, and I talked to him, and I know what he wants. I told him we have it. Let them come, and I will give the Swan gun. And so 747 airplane came to our airport, and I was there escorted by the police. For this $25 catheter, I gave them, and they went to use it. In fact, we have the luxury of we have enough space. We made one area female CCU so that we don't have to worry, even though they are a special room. But look at the census. Let's look at the census of our how much number, 5 patients per month, and look what happened in the end. Our mortality improved. Now these are landmark of cardiology: the pacemaker, CCU, cath lab, cardiac surgery, PTCA, thrombolysis, stent, and the heart hospital. Now I will go briefly to tell you about our registry. Now I was not at that time seeking to publish paper from Qatar, but I want quality assurance. I want to monitor, are we doing well or not? So when we moved to Hamad Hospital, we have a computer section. I asked them if they could do registry for me of our patients. And they said yes. And they did first 8 years, but I was not knowing anything about computer. But then I found out when I start to learn computer and I get expertise in FoxPro, that they are using word processing, which is not really good. So we stopped it and start a new one. These are the study of the first one. At least I am concentrating on the mortality dropping, and look at the mortality in red and the average age. The Qataris' average age is higher and mortality is higher, but compare the male and female at that time, the female are older in age and their mortality is higher. Now the new database, now if you look at it, our database go all total 36 years. The second database, we have about 60,000 patients in it. And look at the MI patient who were aspirin, just for my interest, I want to see. In the beginning, nobody really on aspirin, but then we admit them about 28%. But look at this charge now. According to the modern therapy, we are up to date. 95.7% of our patients discharge on aspirin, which is good. Again, the Qatari have higher age for MI. The smoker over the years in the population of the cardiology, they are dropping nicely. I borrowed this from one of my colleagues to see that our mortality, comparing people who had PCI, who had acute MI, and those who have, in general, an average about 2.5 for PCI and about 4 for the general all case. And the last slide I want to show you is the mortality over the years of our patients. Of course, it fluctuates. We don't know why. Sometimes it goes up and sometimes down. But in general, we started with over 16% of mortality death in our patient. To the end, about 4. And this is general and not specifically filter for PCI or thrombolysis. And so I think I would say we are happy with the result, and we will keep progressing for future, for the new generation of our cardiologists now. We will watch and be happy with their progress, and I'm sure they will do a better job than when we did, and thank you.
Thank you, Dr. Hajar. MashaAllah, you covered everything. Now, I would like to welcome Dr. Mohammed Zubaid. Dr. Mohammed Zubaid is a professor of the medicine at the Faculty of Medicine, Kuwait University. He heads the Division of Cardiology at Mubarak Al-Kabir Hospital. Currently, he is the president of the Gulf Heart Association since January 2016. Welcome, Dr. Mohammed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. مساكم الله بالخير. لسوء الحظ أنا لست بلباقة ولا رشاقة الدكتور حجر البن علي، ولكن سوف أختصر الكلمة. كنت أود أن أبدأ بالشكر لسعادة الدكتورة هناء الكواري على حضورها ودعمها لهذا المؤتمر، ومؤسسة حمد الطبية. فشكرا جزيل الشكر دكتورة ويعطيك العافية. وكذلك أود أن أشكر زملائنا في قطر على الجهد الكبير اللي بذلوه للترتيب لهذا المؤتمر، فيعطيهم ألف عافية. كنت أود أن أذكر باختصار مسيرة بسيطة وأركز على نقطتين بمسيرة جمعية القلب الخليجية التي تشرفنا بالاشتراك معها وبدون مبالغة بقيادة الدكتور حجر بن علي اللي كان له الرؤية لتسجيلها بطريقة رسمية والتي مكنتنا للعمل بطريقة صحيحة خلال السنوات السابقة. ولعل من أهم الأمرين الذي استطعنا النجاح فيهم في مسعى هذه الجمعية هو جلب أطباء القلب على مستوى الخليج للعمل مع بعض، وبالفعل استطعنا العمل مع بعض ومن خلال لقاءات عديدة ومؤتمرات عديدة في كل سنة في كل دولة من دول مجلس التعاون زائد اليمن. هناك تقارب وتعاون شديد بين الأطباء في هذا المجال، في مجال القلب. والمجال الآخر اللي نجحنا فيه هو مجال الأبحاث، وإحنا اليوم نعلم أن ما راح يكون في أي تقدم أو تطور في خدمة المريض إذا لم يكن هناك سند بحثي وعلمي لكي يعزز هذا العمل. وجمعية القلب الخليجية عن طريق جلب الأطباء مع بعض، جلبهم تحت يعني شعار واحد، والعمل على احتضان مؤتمراتهم واحتضان الأفكار، استطاعت أن يعني تطور من عمل الأبحاث. واليوم جمعية القلب الخليجية متواجدة في جميع المؤتمرات العالمية ولها دور بارز. والدليل على ذلك السادة اللي أود أن أشكرهم الموجودين معنا، رؤساء جمعية القلب الأمريكية والAHA والسكاي والWHF والESC، فهذا دليل على نجاح هذه الاجتماعات. فقبل أن أبدأ بالترجمة السريعة للإنجليزي أقول شكرا قطر وشكرا سعادة الوزيرة ومؤسسة حمد على هذا السبورت. Dear colleagues, and I was just starting by saying I'm not as elaborate and as good looking as Dr. Hajar, but I'll try to do a brief job. And I started by thanking Her Excellency the Minister of Health for the great support she provided to this conference. I'd like to thank our colleagues in Qatar for the great organization, and like to thank the presidents of AHA, ACC, ESC, WHF, and SKY who are joining us. And this is an evidence for the collaboration that exists today. During each of those conferences in Europe and North America, Gulf Heart Association has a session. There's a great deal of collaboration. And there's probably two pathways that we've been successful in over the past few years. One pathway is bringing the cardiology community and colleagues together from all the 6 GCC countries and Yemen, and we've been able to do that. We've brought our colleagues in a very good shape, and we've had very successful meetings and etc. And the other part is research, and we believe that any clinical progress, treatment of patients, patient care, health care cannot proceed without a proper scientific research. And over the years, the Gulf Heart Association has been instrumental in sponsoring and facilitating research in the region. And it's this research that has enabled us to be able to stand and present at these different international meetings. One item I forgot in Arabic, but now I remembered it, so I'll say it in English. One issue that we as GHA, I would say we have failed to achieve so far, is communicating with the officials in the Gulf countries, in our countries, with the governments, with the ministries of health, to advance and influence patient care. We've been trying to do that, but I don't think we've done a great job. And perhaps the presence of Her Excellency, the Minister of Health, can ignite this kind of thing where the official government institutions with people like us can come together and establish pathways for patient health care. And my presidency ends tonight or tomorrow at noon, and Dr. Kadhim Suleiman from Oman will be our coming president as of tomorrow, 12:30. So we'd like to welcome him. And again, thank you, Qatar, thank you, Your Excellency, and thank you for everybody. Thanks.
Just the time is running fast. And I like to welcome now Dr. Mary Walsh is the current president of the ACC. She is the past president of the Indian Affiliate of the American Heart Association. She is the medical director of the Heart Failure and Cardio Transplantation Program and the director of nuclear cardiology at St. Vincent Heart Center. Welcome, Dr. Mary.
10 minutes. Thank you so much. I'm very pleased to be here and bring you greetings from other members of the ACC. We have a very warm relationship with the Gulf Heart Association, and we're looking forward to participating in the meeting. I wanted to take this opportunity not to tell you about everything about the American College of Cardiology, as we often do at an opening session, but to focus on our efforts on diversity, which has been a very important and current effort on the part of our Board of Trustees. So why do we want to focus on diversity in medicine? Medicine must be a diverse field because in order to serve diverse patient populations, we need to be diverse ourselves. We also know that with diversity, we will promote health equity, engage our communities, bring different points of view, foster team-based care and prevent disease, and then investigate a broad range of perspectives in scholarly activities. So this is the imperative for diversity in medicine. In comparison to the U.S. population, I'm just going to show you U.S. data. Adult cardiology is far less diverse as a profession than the United States population. An ACC 2016 Professional Life Survey suggests that African American cardiologists and Hispanic cardiologists each represent only 3% and 6% of ACC membership. Fewer than 10% of medical students and less than 3% of faculty are African American in the United States, and 5.5% or so of cardiology trainees were African American, 6.8% Hispanic, which is lower than the percentages in the entire field of medicine. So we realize that cardiovascular medicine as a profession is very non-diverse in the United States. Similarly, if we compare the U.S. population to adult cardiology, we are woefully underserved by women. The United States population is over half women now, and this is really a banner year for women cardiologists. There are many women who are the presidents of professional societies around the world, including Dr. Cassidy's in the audience, the incoming president of the ESC, the presidents of Canada, Great Britain, incoming president of France, and Pakistan are all women. So it's kind of been a banner year for women leaders. However, we have very few women in cardiology still. If we look at the growth in women cardiologists over time compared to other specialties, this slide shows you 2007 compared to 2015, and we see growth in many of the specialties, but not really in cardiology, only 9.7 up to 13.3%. We are very similar to the surgical subspecialties in this way. So if we look at trainees by sex over the time from 2015-2016, you can see that there are lots of internal medicine residents. Currently in the United States, 43% of internal medicine residents are women, and only 21% are cardiology fellows. So the way we view this really is a cardiology talent gap. We are missing 2/3 of those trainees who may want to go into our field, but for reasons we don't understand well, they are not yet going into cardiology. This is even more pronounced if we look at interventional cardiology and electrophysiology. The drop-off from general cardiology to these invasive subspecialties is very steep. So we have a lot of work to do. Diversity and inclusion we know are essential to the successful realization of the ACC missions, values, patient health, and strategic business goals. And it is for that reason that we turned our attention to diversity in our profession in the last year or so. To address these issues, the American College of Cardiology formed a task force on diversity in 2017. The task force was charged with providing recommendations to the Board of Trustees to enable the achievement of the goals that you see, 3 primary goals: to ensure that both cardiovascular medicine in general, as well as the American College of Cardiology as a professional specialty society, will benefit from diversity in background and perspectives in leadership, healthcare delivery, education, and science. Secondly, to ensure that both cardiovascular medicine, broadly writ, along with our professional society, provides rewarding careers and leadership opportunities for the full range of diverse individuals. And thirdly, to ensure that the diverse health needs of the cardiovascular patient populations are met by cardiovascular clinicians who are of diverse backgrounds. These are the people who formed the Task Force on Diversity. Dr. Pam Douglas, past president, chairs the task force. Kim Williams, vice chair. He's another past president. And you can see that there are many individuals from other organizations. Dr. Cassidy represents ESC. We have several diversity officers from universities and medical schools who are serving on this as well. So here's where we are today. The task force has provided the Board of Trustees with a draft strategic plan, and we'll be working on goals going forward, and we anticipate at our meeting of the Board of Trustees at the end of this month that the task force will present some recommendations to us. Here we see the diversity and inclusion draft vision and core values, and I won't go through this in detail with you, but the mission and core values include those goals that we've already mentioned. The draft first objective is to enhance the culture within the cardiology profession and the perceptions of the field to be inclusive, professional, equitable, and welcoming. And if we look at this graphic, it shows us that in order to deepen the pipeline means coming from medical schools, how are we going to get those medical students who have not yet considered the field of cardiovascular disease? We deepen the pipeline, we recruit them, then we have to retain and develop leadership for these individuals who go into cardiovascular disease as a profession. Draft objective number 2 is to realize and sustain the value of diversity over the long term by implementing structures and continuous improvement programs within the ACC so that we actually are holding ourselves accountable for the execution of this plan. And the third objective is to engage and leverage all available talent by attracting and providing value to underrepresented groups in cardiology. As I've already showed you, these are members of underrepresented groups such as African Americans and Hispanics and women. We also know, however, that although the Asian population is well represented in cardiovascular disease, there is what has been called a bamboo ceiling, where we don't see as many leaders of Asian ethnicity in our society and in cardiovascular medicine in general. So our initiatives launching in the next year or so are going to be many-fold. The Diversity Task Force, we anticipate, will tell us as the Board of Trustees that we will need a standing committee to deal with the issues of diversity going forward. We want to make certain that our ACC communications in general reflect diversity. We want to build relationships with multiple partners. Those include other professional societies, such as this one and those represented in this room today, but also other partners, other societies, the American College of Physicians, and others who are facing similar issues in their society. These are we anticipate that workforce-related policy statements will come out of our diversity work, and this is important to engage our government officials and legislation around issues that may involve health policy. Our program directors of fellowship training programs, internal medicine training programs, and even our medical school professors are those who we want to engage in recruitment and retention. We will have a more robust database of ACC membership so that we can readily identify expertise of our members and look at ethnic diversity and gender diversity when we're assigning roles in committee meetings, for example, and lectures. And you can see the other diversity initiatives. I won't go through all of them in the interest of time. We've done a very good job, I think, and the Diversity Task Force has, in engaging our entire membership. We had a survey of our entire membership that closed on November 4th, and we had a virtual town hall in November as well, where all members of the ACC could get on the town hall, hear what Dr. Douglas and Dr. Williams had to say, and pose questions to them and ask about the college's views in this regard. We also had a very prominent publication in Cardiology Magazine just outlining all these issues of diversity that I've told you about and aiming the readers of that magazine toward what we anticipate doing in the future. And with that, I'll end since we're running short on time. Thank you very much for having me.
Thanks for Dr. Mary Walsh. Now I would like to welcome Dr. Sidney Smith. Dr. Sidney Smith is a professor of medicine, a division of cardiology at the University of North Carolina. He is a past president of the American Heart Association, AHA. He chaired several ACC, AHA task force groups of many cardiovascular guidelines. Dr. Smith is the past president of the World Heart Federation, WHF, and chaired the scientific advisory board of the WHF. Welcome, Dr. Smith.
Well, thank you for that warm welcome, and I'd also like to thank you for the honor of inviting me to participate in the meeting here. It's a great pleasure to return to Doha and join you for these meetings. And I bring greetings from all at American Heart Association, where we again have a strong relationship. I'd like to talk a little bit this evening about an area which is important to American Heart and has been especially important to me over the last 2 decades, and that is quality improvement. And I've worked on this through the guidelines with the American College of Cardiology, American Heart, through the World Heart Federation, and now through the American Heart Association. The American Heart Association is known for its support in science. They've contributed over $4 billion to basic research since 1949, and 14 Nobel laureates can claim research support from American Heart along the way. The 37% of the grants that are given now are international. So there is a strong interest in American Heart in supporting basic research and young investigators, but also a very strong interest in quality improvement and addressing directly the global burden of cardiovascular disease. So we'll talk a little bit about that. It's well known now, and I think you all have seen this slide, the burden of cardiovascular disease. Cardiovascular disease is the #1 killer in the world. Every 2 seconds, someone dies in the world from cardiovascular disease. Almost $1 trillion are spent on cardiovascular disease. It far exceeds infectious disease and other causes of mortality. For that reason, the World Health Organization had its first major meeting on non-communicable diseases back in 2011. I had the honor to speak at that meeting. Since that time, there have been many programs initiated. Importantly, the goal or target of a 25% reduction in premature mortality from non-communicable diseases, and this extends to cardiovascular disease, was adopted. And this is, I think, a challenge for all of us, whether we live in the Middle East, United States, or Asia. This has prompted the organizations in the world in cardiology to work together. And one of my messages tonight is that we need to, as societies, work together. Several papers, this is the first issued by the World Heart Federation, American Heart, American College, the European Society of Cardiology, and others on the need for us to begin to work together. It's been followed by other important publications, this one on sustainable development goals. So the programs are well underway. They are based on a fundamental concept that was emphasized in the United States by the Institute of Medicine. In the year 2000, our Institute of Medicine came out and said that the United States healthcare program was incapable of delivering care to patients because we were not basing enough of our work on evidence, and that triggered a major action by the American College of Cardiology and American Heart in their guidelines. We saw this also from the European Society on guidelines, focusing more on evidence. At that time, we found that more than 50% of patients were leaving hospitals in the United States without receiving preventive therapy that could prevent a subsequent event. And we saw the very nice data presented just on aspirin by the first speaker here in Doha. So this is not something that existed uniquely in the United States, but it's something that we need to work on. And the medicines that are used are they're generic. You'll hear Dr. Mark Huffman speak tomorrow about the polypill. Will this make a difference? But things like aspirin, beta blocker, ACE inhibitors, statin therapy can substantially reduce subsequent mortality from cardiovascular disease. Now in the United States, because of these quality improvement programs, which are atrial fib, acute coronary syndrome, heart failure, stroke, almost 80% of our population lives within hospitals that are practicing with quality improvement. Over 2,200 hospitals in the United States have these programs underway. So it's beginning to make an impact. If you ask, well, how do we know that evidence-based medicine can make a difference? It's shown here for acute coronary syndromes as the implementation of the guideline recommended therapies increases from less than 65% to more than 80%. On this slide, you can see the reduction in mortality associated with that. This is from the CRUSADE trial. And what we've seen in the United States now over the last 10 years, where we have been focusing on evidence-based medicine and quality improvement programs, has been a 30% reduction in 30-day mortality after myocardial infarction, 16% reduction after heart failure, and almost 5% for stroke. So at a time when cardiovascular disease is increasing globally, we are seeing a decrease in these entities in the United States. These programs work. In the United States, we also have learned that there are differences in care. There are variations in care that relate to ethnicity, they relate to gender, they relate to the use of medication. So these quality improvement programs, as you see on this map of the United States, going from dark blue, which is a low implementation rate, up to gold, help us know where we need to focus our efforts. We also have seen a narrowing of the gap in treatment for women for different ethnicities when quality improvement programs are employed. Finally, when new medical therapy comes out, if quality improvement programs are in place, very quickly the new therapy can be adapted. If the Gulf states come out with guidelines, or Doha, if you have guidelines saying it's now time to use a specific medication, and you have quality improvement going, very quickly it can be implemented. This is just a simple slide showing after the CURE trial came out, which looked at clopidogrel, how rapidly the use of clopidogrel was integrated because of the presence of a quality improvement program at UCLA. Now, the World Heart Federation has addressed this question of whether guidelines, how might guidelines be used. And Dr. David Wood, who will speak to you after these opening remarks as part of this ceremony, was part of the committee. Valentin Fuster, several people that you know, came out with some very fundamental recommendations. Firstly, and you heard this from our second speaker, and I agree totally, that societies and governments must collaborate together. The ministries of health and the societies must work together. In China, we are working with the Ministry of Health. In Brazil, the Ministry of Health is involved in the programs. We're now initiating programs in the UAE. So when the quality improvement programs are initiated, it's very important that the government and societies work together. They need to begin to focus on evidence-based guidelines and begin to look at total cardiovascular risk. So these are some of the recommendations that came from the position paper of the World Heart Federation several years ago. We also recognized that the guideline recommendations will differ based on cultural, social, medical, and economic reasons. Cannot take guidelines from the United States and assume that they're going to be what should be used in Brazil or Chile. They may be adapted. They may need to change to fit different economic, medical, and social situations. So important to have guidelines specific for a country where we're working. Talk a little bit about China. If you look in blue, you'll see the mortality from acute coronary syndrome and stroke is roughly equivalent in China right now. By the year 2030, the mortality from acute coronary syndrome in China will triple almost. Similarly for stroke, more than triple. This is why the Ministry of Health in China is so interested in the programs that we are doing. We now have 150 hospitals throughout China that are involved in quality improvement programs. Over 2 years, almost 100,000 patients have been entered. Roughly 35,000 for atrial fibrillation and over 60,000 for acute coronary syndrome. What we are seeing in China is shown here. This is a map of China looking at the use of anticoagulants for atrial fibrillation, and you can see it varies significantly. The chartreuse yellow color there are areas where it's very highly implemented. The whole top part of the map extending from Dongbei, from Harbin in the northeast, across Inner Mongolia out to Xinjiang, out in the western part of China, Urumqi. Very low use of anticoagulants. This is important information for the Ministry of Health in terms of how to focus educational, both for patients and for doctors. So the Quality Improvement Program not only identifies areas that need work, but improves the use of the medication. Similarly, the programs are underway in Brazil. In Brazil, we are focusing on the SUS hospitals, which provide 80% of the care in Brazil. Atrial fibrillation, congestive heart failure, and acute coronary syndrome already underway with quality improvement. And just in November, guideline-related programs on heart failure, stroke, atrial fib are being launched in Dubai. And there are other discussions in the Middle East about quality improvement. I just want to conclude with another concern that I have, having worked on guidelines for the last 20 years, and that is that the evidence is not available for the majority of the world in randomized clinical trials. This looks at the enrollment of patients in randomized clinical trials. You can see that if you live in Western Europe, North America, fine, there are a lot of patients enrolled. But in China, only 2% of the total enrollment for randomized trials came from China. I show at the bottom the Middle East and South America. Only 2 to 3% of the enrollment has come from these countries. We really need to have data broadly at an international level to address some of these issues. For example, the DAP trial, which I was involved in a guideline update on dual antiplatelet therapy. If you look at the enrollment of patients, you can see no patients from South America, no patients from Asia, no patients from the Middle East. So exactly how do these data, which are obtained mainly from Western Europe and North America, apply to the rest of the world? And I had the opportunity to talk with one of the investigators, who is a very close friend. I said, I don't see anything from Asia. And the response was, well, we got Australia. I said, wait a minute, Australia's not even in Asia. It's a different continent. You need to think about geography. So I would enter a plea here that we begin to look at our programs and our research efforts to extend more broadly. In China, to conclude, we have initiated and will be training nurses. And you heard, again, the first speaker talking about the need for specialized nursing. Doctors are not going to be able to take care of this epidemic on their own. It's too big. We don't have enough. We're working now for the first time ever. China, the Chinese Nursing Association, has agreed to certify nurses specializing in cardiovascular disease. So they will undergo training using a program developed at Stanford and in 12 pilot hospitals, begin to look at outpatient secondary prevention and home cardiac rehab. I think in conclusion, we've focused on the fact that cardiovascular disease is a leading cause of global mortality. So the work we're doing is important. This is something that's needed broadly by all of us in this room. The WHO goal stands before us of a 25% reduction in premature morbidity and mortality by 2015. I firmly believe that our governments, our societies, and we as cardiologists need to look at how we can work together to make this happen. Quality improvement programs has been a major focus for me. It's a major program at American Heart. In other areas, I think that can make a difference. We need more evidence. And finally, we need to look at including a broader group of healthcare providers in these efforts if we're going to be successful. I'm down to 9 seconds, so I want to conclude by again thanking you. I'm looking forward to these meetings and very honored to be here.
Thank you, Dr. Smith. Now I would like to welcome Dr. Jan Box. He is the professor of the cardiology and director of non-invasive cardiac imaging at the Department of Cardiology, Leiden University Medical Center, the Netherlands. He is the current serving as the president of the ESC. Welcome, Dr. Jan Box. And I hope just short speech because I think we got a lot of things to do. Thank you so much.
Well, I give you a short speech. I am happy to be here. I've been in the last couple of years to several of your countries, to several of your states, and I witnessed that the world starts to become more together as one. We are all looking at the same things. I'm looking here at the first row where I got to know many of you, and I appreciate the friendship and the openness that you share with us. I think we should work and build together. Many of the things that I have here in these few slides that I collected have been said before. These are the realities. Despite these huge advances in cardiovascular medicine that we all witness on a day-to-day basis, that was summarized so nicely in this first talk of the first speaker, cardiovascular disease remains the #1 killer in the world. Depends a little bit how you look at things. It's either oncology or cardiology. But most of the times, if we look at the statistics, it is cardiology. I plotted here 17.5 million deaths globally, which is 31% of all deaths. I plotted here 3.9 million deaths per year in Europe alone, which is 45% of all the deaths that we witness. And what we see that is coming more and more with huge, staggering costs. We are focusing a lot in cardiovascular medicine on treating and focusing on the patients with the advanced disease, with the introduction of transcatheter valves, more important interventional strategies, moving all the way to severe heart failure, focusing on almost artificial hearts. The costs go up and up and up. If you look at Western Europe, where a lot of the money is spent, it's in the heart failure clinics, which is completely the opposite end, as Dr. Smith was mentioning. We should therefore, and I heard Val Fuster speak many times on this, focus on prevention and prevention and prevention. And then I'm not talking about, let's say, 35-year-old people. I'm talking about the work that Val Fuster is now starting, looking at schools, young children, bringing them computer programs, how they can live a healthy lifestyle. And when I was visiting him in December, he showed me the results when comparing these schools in Spain, where he showed that the ones that were living according to such computer programs stimulated not only the outcome and the development of these children in terms of developing obesity, etc., but it stimulated the entire family to adopt a completely different lifestyle. He started his work, he tried to start it in the US with looking at Sesame Street. And in Sesame Street, he looked at Cookie Monster. And Cookie Monster, he proposed to take some more apples and maybe one cookie a week. He tried to pull it off in the US. They didn't do it. So he moved to Mexico. And he moved to Colombia. And they did do it over there. And the outcome was staggering. That's what he showed me the last time. And he was very proud to show that finally now he was going to have some implementations in the United States. So if we look at the economic costs of cardiovascular disease to the EU economies is very, very expensive, estimated 210 billion euros per year. But if we go more to the other side, if we go to these young generations, if we focus in all different countries on these young, 80% is estimated to be preventable. This is staggering. And this, I believe, should be the main goal of any cardiovascular society as we're sitting here. And efforts to reduce that, treating patients have been successful, but the ultimate is to switch really in the direction of prevention. These are the sort of figures that we all know. This is the aging pyramid. On the y-axis is the age, and you see here the difference men and women. And here you see the predictions in 2050. So despite the fact, all the efforts we undertake at a later stage to work with people, despite the facts, we see that with the aging population, there will be much more cardiovascular disease, diabetes, hypertension, stroke, infarction. That's what's coming. That's what's coming to you and is coming to us. And there is only one solution. We have to treat. We have to look at the patient central. We have to focus on therapies there. We have to keep focusing on end-stage heart failure. But the real shift is going to come, and I'm sure David Wood will speak about it, about prevention. And that means not going to the 35-year-olds, but means going to the 5-year-olds. We and you, we have the same sort of mission statements to reduce the burden of cardiovascular disease. I hope that one day we will change that to prevent the burden of cardiovascular disease. Our core strategic objectives in ESC are to advocate for quality of cardiovascular care, to apply standard and guidelines. You heard Sid Smith speak about guidelines, and that is actually what it's all about, adhering to systematic implementation of modern therapies, disseminating scientific knowledge of the highest qualities. That's what you do here in the next couple of days. That's what we do in Europe. That's what you do in the United States. To serve the interest of the patients if we are still not at the level of prevention, us doctors should focus on the patient. The patient is the central theme in everything we do. Building a strong community of cardiovascular specialists by working together to advance cardiovascular science and help people live longer, healthier lives. We in ESC have started to move beyond our borders. You see in red, which represents the European Society of Cardiology. In green is the part of the world that we work with. These are our affiliated societies. The slide is a little bit older because we are now over approximately 120,000 international members. And we work within green throughout the world with these strong affiliated cardiac societies. Among the top 5 I checked is what you are doing together here. And we're thankful for that. We thank you for working with us. You have a large membership. You advocate strong quality and care. You focus on education and you shift your focus to innovation. These are the things that we try to do at ESC as well. This is where we meet each other. Our strategic plan, and I like to show that again and again because this is really the pillars that we work on. Advocacy. Why advocacy? Because the care in Europe, as I saw on some of the slides, is not equal. During my presidency and before that, I traveled to a lot of countries in Europe, and it is staggering to see that if you visit Bulgaria, for example, that an average cardiologist of 55 years old makes a monthly salary of 800 euros. These people cannot leave the parental house. And when we come there and we say, join our Congress, which costs an entrance fee of 450 euros, they look at me and they say, how can we do that? This is in Europe. This is today. So we look and focus on advocacy. We focus on research. We're not going to do research ourselves. We're going to help in designing of large trials that will make a difference. We focus on education. That's probably our strongest focus. Education, working with people all around the world to disseminate care for quality. We have a strong Congress, same as you have. It is still the Congress that's the main driver of our education. And the platform, as we believe, at the end of the day, is going to be membership. And membership is not just simply being a member, but our next generation asks for different ways of membership. That means personalized membership. That you work together, and if you are interested in electrophysiology, when I look at the far left in the first row, you have different needs than if you work in intervention. And therefore we believe that personalized membership is the answer to this diversity. But at the same, we like to keep cardiology as one whole and avoid fragmentation in subspecialties. Because again, at the end of the day, is the patient that's central. And a patient is not an EP patient. And a patient is not an interventional patient. But a patient is a holistic individual. We, you and us, we invest in education, leading congresses. I've been here now a few times and I'm always impressed with the quality of your education, what you present. We exchange sessions and we exchange leaderships, as we will do here, as we do at ESC. We enjoy your different congresses. This is probably the most important slide that ESC is focusing on. Like we're focusing on prevention eventually, we're also focusing on the next generation. If I look here through the room, I do not see so much young cardiologists. But these are the ones that eventually going to take care of us. This is, if you're not only being selfish, where the main investment should go. So within ESC, we have for all these different specialties, young cardiologists being grouped together. And this is what's going to bring the next generation. When you look at the next generation, it's very different. There are lots of differences in the way we work and the way they work. And that is what we should try to bridge. And that's why we should connect them with us. And that is one strong focus we do. I'd like to end here that all these different activities, we cannot do just as one country, just as one society. The world is not different in Asia, in the Middle East, in Europe, in South Africa, in South America, in the United States. These activities that we just discussed in all the different talks, they cannot occur without a strong global network. And that is what brings us all, as we sit here from wherever we come, together. I want to thank, on behalf of the European Society of Cardiology, the Gulf Heart Association, for their continued support. It means a lot to us. We congratulate you also with a fantastic meeting. Thank you very much.
Thank you, Dr. Jerome Box. Now I would like to welcome Dr. David Wood. Dr. David Wood is the Professor of Cardiovascular Medicine and Honorary Consultant Cardiologist, National Heart and Lung Institute, Imperial College London. Dr. Wood is the founder and President of the European Association for Cardiovascular Prevention and Rehabilitation. Currently serves as President of WHF. Welcome, Dr. Wood.
May I begin by thanking my good friend and colleague, Professor Mohammed Zubaid, and the board of the Gulf Heart Association for this opportunity to represent the leadership of the World Heart Federation at the Gulf Heart Association Congress. It is a privilege to be asked and a pleasure to be in your company. And I want to address the work of the World Heart Federation, which embraces both the continental and national societies of cardiology, our professional societies, but also the continental and national heart foundations representing the patient voice drawn together within the World Heart Federation. And we are the lead partner to the World Health Organization representing the global cardiovascular community. And we align our members and the broader circulatory community with our mission for cardiovascular health. Our flagship meeting is our Global Summit on Circulatory Health, which was launched in Mexico in June 2016. We held our second Global Summit in Singapore in July last year in partnership with the Asia Pacific Society of Cardiology and the Asia Pacific Heart Network. These summits embrace a broader constituency than cardiology and heart foundations. We look to the leaders of all of the international organizations which are stakeholders in circulatory health. And the purpose of this meeting was to accelerate action around prevention of cardiovascular disease, the number one killer worldwide. And this summit, chaired by Richard Horton from The Lancet, concluded over a 2-day period to form a global coalition for circulatory health to unite the international civil society movement. And this coalition was officially launched at the WHO Global Conference on Non-Communicable Diseases in Montevideo in October last year. You may not have heard about this meeting, but you probably read about the announcement of Robert Mugabe as the new WHO ambassador for non-communicable diseases, a position which was subsequently rescinded but hit the international press. And this global coalition is open to any professional organization at an international, regional, or national level with an interest in circulatory health. And Richard Horton published a short piece in The Lancet describing this global coalition and its objectives. The vision is to achieve a 30% reduction in premature mortality from heart attacks and strokes by the year 2030. This comes from the UN Sustainable Development Goals of 30 by 30. And the partnership that we are creating is open to all international, regional and national organizations in the field of heart disease and stroke. The leadership group comprises the presidents and CEOs of each of these international organizations in official relations with WHO. And we have set ourselves 3 objectives, and the first is to enhance global advocacy for prevention and control of heart disease and stroke by building and investing in advocacy skills and including the development of patient advocates. We see advocacy as being the single most important driver for change in relation to politicians and policymakers. Secondly, to support governments in their efforts to develop and implement strong and sustainable national CVD action plans. You may be surprised to know that despite the UN high-level meeting in 2011 and the call for prevention and control of non-communicable diseases, that the majority of governments do not have a national action plan for prevention and control of cardiovascular disease. And we believe that we can support governments in their efforts to prevent and control cardiovascular disease by encouraging the development of national guidelines on cardiovascular disease prevention, providing education and training of health professionals beyond cardiology in preventive cardiology, and by surveillance, by measuring the burden and treatment of cardiovascular disease. Now, these epidemiological data created by Salim Youssef from the PURE study illustrate the challenge that we face worldwide. This first figure shows the prevalence of risk factors as measured by the Interheart Risk Score in high-income countries from the left through middle-income to low-income countries on the right, for urban areas in blue and for rural areas in red. And as you will see, it is the high-income countries that carry the highest burden of cardiovascular risk. And yet, paradoxically, event rates for major cardiovascular disease are lowest in the high-income countries, rising in the middle-income countries, and are highest in the low-income countries. And this is a function of the epidemiological transition, with a falling burden of cardiovascular risk factors in high-income countries and a rapidly increasing burden of cardiovascular risk factors in low-income countries, and most importantly, a higher case fatality rate for cardiovascular disease in low-income countries. You will see here that between high-income countries and low-income countries, there is almost a 4-fold difference in the case fatality rate at 30 days after the presentation of a heart attack or stroke. And this is partly a function of the availability of essential medicines and technologies, as illustrated by this figure. On the left, you see the use of drugs for patients with coronary disease, and on the right, the use of drugs for patients with stroke. And if you move from left to right, from high income to upper middle income, lower middle income, and low income countries, for both coronary disease and stroke, you will see that a majority of patients are on no evidence-based drug therapies whatsoever, a major contributing factor to the very high case fatality rate seen in the low-income countries. And the third objective of this newly formed global coalition is to communicate through all of our organizations, to speak with one voice, because we believe that we may be stronger in our abilities to influence politicians and policymakers if we are clear about common messaging between our organizations. Now, what role for continental organizations like the Gulf Heart Association and for national societies of cardiology? I think the first and most important role is to demonstrate leadership for prevention of cardiovascular disease. And secondly, to lead the development of all stakeholders in a national coalition for cardiovascular disease prevention. Thirdly, to develop guidelines for cardiovascular disease prevention, to provide education and training of healthcare professionals in preventive cardiology, and finally to audit the standards of cardiovascular disease prevention. These are the hallmarks by which one can judge the role of a continental and national society in the context of cardiovascular disease prevention. Is there leadership? Is there a national coalition? Are there guidelines? Is there education and training? And is there data showing the standards of care that are being achieved in terms of prevention and control? Our third Global Summit on Circulatory Health is being convened in Dubai in the United Arab Emirates on December 4th and 5th of this year, and it immediately precedes the World Congress of Cardiology and Cardiovascular Health in the same location. And I'm very proud to say that this World Congress of Cardiology is being organized in full partnership with the Gulf Heart Association and with the host, the Emirates Cardiac Society. Now, I'd like to conclude with a recent visit I made. I had the privilege to attend the 50th anniversary of the first human-to-human heart transplant at Groote Schuur Hospital in Cape Town, South Africa, which took place on December 3rd last year. I was a 17-year-old boy just about to go to medical school when news of this extraordinary surgical feat reached the international press. And in researching for my remarks at this meeting, I came across the following quotation from Christian Barnard. I have saved the lives of 150 people by heart transplants. If I had focused on preventive medicine earlier, I might have saved 150 million. And I think it is incumbent on each of us as cardiologists and physicians managing patients one by one, individual by individual, to think more broadly about the causes of cardiovascular disease in the population at large and how the burden of this disease can be reduced through prevention and control. Thank you very much.
Thank you, Dr. Wood. Now we have a last speaker, Dr. Hanan. She is busy. So Dr. Kirk Garrett, the current president of the Society for the Cardiovascular Angiography and Intervention. He also serves as a director, Center of Heart and Vascular Health, Section Chief Cardiology and Director, Cardiovascular Research in Wellington, Delaware. Welcome, Dr. Garrett.
Thank you very much. And like the other speakers, let me begin by thanking the course organizers for giving me the opportunity to represent my society here this evening. Your warm hospitality has been incredibly touching this past 12 hours while I've been in Doha. I would note that the hour is late and we all are fatigued after a long and busy day, so I'll keep my remarks very short. I did note that a 40-year span of time can really create enormous change. We saw that demonstrated in what's happened here in Qatar, in the formation of cardiovascular services from a very fundamental state to a very high level in just 4 short decades. It's been exactly 4 decades as well that we've had the opportunity to intervene into living hearts in conscious patients in the catheterization laboratory. And it was that ability that was the root cause for the formation of the Society for Cardiovascular Angiography and Interventions in 1978. It started off with the concern that perhaps we weren't doing diagnostic work correctly, but of course with Andreas Grunzig's seminal work in Europe coming out at about the same time, the focus of the organization shifted sharply and has never lost its focus on the interventional work that we do. And if I could just summarize my impressions of what's been said this evening by all the prior speakers, I would observe the following, that the lessons that have been underscored by every speaker so far this evening, in my mind, have been the following. First, we have worked hard and we have realized enormous gains. We have done good work and we have helped people in a very material way. We also have a lot of opportunity ahead to do even better. And the most salient lesson, I think, is that if you have focus of vision and a clear idea of what you can do personally to improve the outcomes of the patients you see in the future, and you have the resolve to work hard to get it done, you will realize additional gains. And what more can we really want to say as we launch an important Congress like this one? If we maintain our vision, and if we have resolve, if we're willing to learn, willing to take our learnings home, put them to work in the care of the next patient we touch, think broadly beyond just that individual patient, more globally, and partner, we can't lose. The challenges for SCAI today are quite different than the challenges faced by the more global organizations that are represented here this evening. In that, my membership also is worried about how we're going to do a better job of the next patient. We're also worried about how we can be more effective in rendering the services that we render. But the World Heart Federation doesn't need to worry terribly about overuse of statins in a patient with hypercholesterolemia or excessive use of aspirin, low-dose aspirin in patients who have had an ischemic event. I need to worry about those things because interventional cardiologists have historically been eager to adopt and slow to abandon. It's just a fact. We live in an evolving world, and over the past 40 years, we have been able to develop enormously useful tools. We have pushed the boundaries hard, which is appropriate, and at times we've found we've overreached, and we have to recant and retrench, and that's also appropriate. And part of the challenge for an organization like SCAI is to assure that its membership is aware of the current boundaries and aware of how proper performance looks in the current environment. I like the challenge. I think it's a terrific challenge to have, and I welcome the opportunity to partner with organizations like ACC and ESC and World Heart. And I think we can do an even better job if we serve as a team in this regard. I'll just close by saying again that it's a wonderful thing to have the opportunity to represent a specialty society at a phenomenal meeting of this type. I look forward to meeting all of you during the next several days and engaging with you. I do think that if we partner well, we have great success ahead. Thanks so much again.
Thank you, Dr. Garib. Now I would like to thank Dr. Hanan Al-Kuwari, the Minister of Public Health, Dr. Hajar, and all our speakers and all our attending today. Now we would like to invite Dr. Hanan Al-Kuwari, the Minister of Public Health, and Dr. Hajar and our speakers, our guests, to open the medical exhibition. Then we will go for the dinner for the speakers and moderators at the gala dinner at the garden. And the rest of the people, we have a big dinner here just behind the exhibition. Thank you for coming. Thank you for attending. Thank you so much.